Hello and welcome this morning to Ask Me Anything Live here on Instagram. We have with us today Karen Adams. She is the new director of the Menopause and Healthy Aging program here at Stanford. Welcome.
Thank you. Happy to be here.
Great to have you. So we're going to talk about menopause today. Let's start off really simply. What is menopause?
The definition of menopause is no period for a year. So the average age of that is about 51. It's pretty rare to still be having periods by 55, but on average it's about 51. So no period for a year, we only recognize that in the rearview mirror, right? You don't know when you're having that last period,
Right.
but you sure know when you're perimenopausal because that's the lead up time.
Why is, menopause is pretty much a water cooler topic. But a lot of women, a lot of people don't like talking about it. Why is it such a taboo subject?
Right. It's I wonder that a lot because I talk about it all day long, every day. But my patients tell me that they talk to their daughters about what's happening as they're going through puberty, but no one talks to them about what's going on now that they're 48, 50, 52. Many of them say, my mom's not around anymore. And when she was, she didn't talk to me about it. So I think some of it is cultural, some of it is just that feeling of the negative impact of aging. But I'm here to tell you that it's great on the other side. And I think that message is finally getting out there, that it's wonderful to be postmenopausal.
It's good to get that message out there. But sometimes many women feel that their symptoms, their complaints, they're being ignored. Why is that?
Well, I think there's a couple of reasons for that, and I don't think they're making that up. I think that's really true. A big part of it is because many people who are practicing medicine, nurse practitioners, physician assistants, physicians, were not well trained about how to take care of menopausal people. And there's lots of reasons for that we can talk about. But many women go to their doctors and they say, this is what's happening. And the doctor says, well, you know what, you're 52, what do you expect? And so I think they're searching for good information. And thankfully, they're not accepting that answer anymore. And so that's a big part of what we're doing here at Stanford, is to really educate not just patients, but providers as well.
And part of that education has to do with the phases of menopause. Let's talk about perimenopause.
Yes, so perimenopause is the period of time leading up to menopause. So we already said menopause is no period for a year. But that doesn't happen like flipping a light switch. It's not like you have periods every month and then boom, the last one and it stops. There is a period of time where the ovary is aging. And we think of your period as kind of your fourth vital sign. So, there's your temperature, your pulse, your blood pressure, and your period. And when you have a period every month, what that's telling you is that your brain is talking to your ovary every month. And it's doing this thing, and the ovary is responding by making hormones, and it's very cyclic, it's very predictable. Every month it happens just the way it did the month before. And as you get into perimenopause, the ovary's aging and it's responding less and less and less to those brain signals. The brain is still talking to the ovary, but the ovary's like, no, not doing it. And then it kind of wakes up and it does this little hormone surge. And so it's 100% unpredictable. So you might have a period, you might not. You might feel normal, you might not. And the perimenopause is this period of time, on average about 4 years, but can be, get this, 10 years. And you're symptomatic. And the symptoms can be worse than they are when you're postmenopausal.
I think that's part of the consternation or impatience that am I in perimenopause? Okay, I thought I was done with my period, but now it's coming back. And so there's a lot of like angst there.
Absolutely. And it really is unpredictable. So I guess that's one message for everyone today is you are not losing your mind. This is real. And it's because your hormones are not cycling in any kind of a predictable way anymore. So you feel off balance, you have hot flushes, you have night sweats, mood disorders, sleep disturbance, brain fog, sometimes vaginal discomfort or pain. The good news is it's all treatable and it's transient. It will not be this way forever most of the time. Some aspects of it might be more long-term, but those are all treatable as well.
We're going to talk about the treatments for menopause, the symptoms. But right now, let's talk about the timing of menopause in terms of, does childbirth affect it? Does hysterectomy or contraceptives?
There are certain things that can affect it. Contraception, no. No contraceptive method impacts the time of menopause. So you can be on a birth control pill for 20 years. That's not going to change the time that you go through menopause. An IUD is not going to change the time you go through menopause. There's a little bit of a genetic component to it. If your mom went through it late or went through it early, that might be helpful for you to be able to tell. Most of us don't know when our moms went through it, though, because they didn't tell us. And then there are some genetic conditions and some surgical conditions and some medical conditions that can cause early menopause.
So let's talk about treatment. For the hot flashes, the night sweating, the mood swings. What is that? What is available to treat those symptoms?
Yes, so there's a lot. How much time do we have? So the number one symptom is hot flushes and night sweats, and 80% of us get those. And so that is probably the single most important thing that drives people to the doctor or to the provider, because they are miserable. And if they're not sure that they're having one, they probably aren't, because it's pretty noticeable. And in fact, it can be visible. Your face gets red, you kind of get sweat. You can kind of feel a little bit of heart speeding up. Yes, and it can almost feel like a panic attack. Sometimes it's incredibly uncomfortable. And the good news is estrogen takes that away in about 3 or 4 weeks. Just basically really brings it down. Some people don't completely have suppression of it, but by 80 or 90%, much, much better. So estrogen is usually the gold standard for treating hot flushes. And then there are some other alternatives as well for people who can't.
Well, what about
don't want to?
Hormone therapy? That's been in the news lately.
Right. So hormone therapy is what we used to call HRT. Now we call it hormone therapy. And it is typically 2 hormones, estrogen and progesterone. And you do those together to provide heart health, bone health, symptom management, and long-term health promotion. The only people who don't need to take estrogen and progesterone together are people who've had a hysterectomy. And if you've had a hysterectomy, you can take estrogen alone. But if you have a uterus, you still need to take both of those.
Are there non-hormonal treatments?
Absolutely, there are. There are a couple of classes of drugs. One is called SSRIs, which is a type of antidepressant. So an SSRI stands for selective serotonin reuptake inhibitor, which basically means...
It's a mouthful.
Right, antidepressant. So that's one group that can be used to treat hot flushes. Another group of drugs is called gabapentin or neuromodulators. And then, newsflash, in May, a brand new drug was approved to treat hot flushes, and it is a non-hormonal method that is available to anyone. The only people who should not take it are people who have renal failure or liver failure, or people who take a couple of unusual medications that most people are not on. So that's a great new option that is just coming to market that we're getting ready to start offering.
So some viable options for those of us who are suffering.
Yes.
I know there are also probably treatments more on the psychological side, how to deal with this, as they call it, the change, the transition.
Right.
Your program here at Stanford, let's talk about that and how it all comes together, the medical aspect, the psychological aspects.
Right, absolutely. So for the longest time, Lisa, the longest time, we told people, oh, paced respirations, slow breathing really decreases the risk of a hot flush, the frequency and severity. And we've started to have more data that says, nope, not so much.
Not while you're like sweating, right? Profusely.
Which is, kind of reassuring for people who are like, this isn't helping me, Yoga sometimes can. The main thing that has been shown to be helpful from a behavioral standpoint is a thing called cognitive behavior therapy, which is everyone should do it. You should do it. I should do it. Everyone should do cognitive behavior therapy. It is such a powerful tool for treating insomnia, for anxiety, for depression, and for the impact of the menopausal symptoms. And so we have experts in cognitive behavior therapy in our Women's Health Center and in the broader Stanford community. And that is probably the single most important aspect of managing your symptoms.
Well, what's part of that therapy? Describe that a little bit more.
It's so interesting. It's a toolkit for managing the thoughts that torture you. And I'm not a therapist, and so I don't provide this to my patients, but what cognitive behavior therapy does is it teaches you to identify what we call cognitive distortions, meaning you say something kind of dumb at the family reunion or in a dinner party, and then you replay it over and over in your head, and you remember every stupid thing you've ever said in your life, and you start thinking, I don't understand why anyone would even want to hang out with me. I'm such a mess.
We've all been there.
Am I the only one? And so it teaches you to just say, wait, stop, and identify those things and then reframe them in a way that's much kinder to ourselves. It's part of the reason we can't sleep at night, because our mind is going. It's not our bodies that's keeping us awake, it's our minds. And so cognitive behavior therapy has been shown to be the most effective treatment for insomnia. Better than trazodone, better than Ambien, better than Benadryl. It's the most effective treatment for depression, for anxiety, and it's incredibly effective for menopausal symptoms. So that, I think, is an important message.
And speaking of menopausal symptoms, at what point do you go see your doctor if you have irregular bleeding?
Right. I think that's a great question. I'm glad you asked that. If your periods are just stretching out and you're skipping some, that's normal. It may not be comfortable, but it's normal. If you're having frequent bleeding, if you're having prolonged bleeding, if you're bleeding 10 days, 12 days, 14 days, if you're bleeding every other week, if you never know, but you're bleeding more than 50% of the time, you should definitely see someone, because that is probably not hormonal. That could be a fibroid or a polyp or, God forbid, cancer. So you definitely don't want to just write that off to being menopause.
Aside from that, what other symptoms are sort of, red flags for you to see your doctor?
Well, I think anytime you're uncomfortable, that you definitely should. 80% of people are going to get hot flushes and night sweats. In perimenopause, 65 to 70% of us get mood changes. So depression, anxiety, irritability, and it's called perimenopausal mood instability, PMI. And we've all heard of PMS, right? I mean, we know what PMS is. One of my goals is to make sure we know what PMI is, and it is as well understood as PMS. we don't talk about this, and people just think they're losing their mind, and they're not. It's hormonally mediated mood changes. So that definitely can be treated. Definitely people should see their physician or their provider in that situation. Sex should not be painful. And if vaginal penetration is painful, that is not normal. That is not a normal part of aging or menopause. 50% of us do not have pain with sex, no matter how old we get. I have a patient who is 80 years old, and she is having sex with no pain and not using anything. And so 50% of us will fall into that category. 50% of us will start having pain, though, and for some people that's before the periods really stop.
So how do you treat that pain? What are the remedies?
Right. Well, it depends on where it's coming from. So the pain, when you have pain with penetration, it can be at the opening of the vagina. It can be halfway up the vagina. It can feel like he's hitting a wall, or your partner or whatever you're inserting is hitting a wall. It can be up in the belly. So the cause of it depends on where it is. In perimenopause and menopause, it's almost always because of what we call genitourinary syndrome of menopause, or what we used to call atrophy. And it's just because the vagina loves estrogen. It loves estrogen. And so estrogen makes the vagina plump and flexible and moist. And our estrogen levels naturally decline in menopause, and some people's vaginas really feel that.
Is that where hormone therapy comes in?
Yes, absolutely. There are 3 different kind of buckets of treatments for that, for vaginal atrophy or pain with sex during menopause. The first bucket are a class of products called vaginal moisturizers. And they are these very cool kind of things that are just available over the counter. They're not a prescription. And 3 times a week, you get out of the shower and you moisturize your face, you moisturize your body, you moisturize your vagina. And you do it by just putting a little plunger in the vagina and squirting out the gel. So there are products that you can Google vaginal moisturizer, and you can find those. Those were designed for people who don't want to take estrogen, and they're not to be used at the time of having sex. They're used at other times, just to create more moisture in the vagina. And then
Kind of a routine.
Yeah, exactly.
Right.
3 times a week. And then lubricant with intercourse is very important with sexual activity. And those can be water-based or oil or silicone. My preference is just coconut oil, plain old coconut oil. It's totally cheap, smells great, it's naturally antifungal, so it will not increase the risk of yeast infections, and it's very slippery, so it stays where you put it, it doesn't absorb into your body, and it just makes the vagina much more slippery and less likely to have little tiny tears or anything. So vaginal moisturizers, lubricant, and then if those 2 things don't work, then vaginal estrogen makes a great big difference for this.
So try the first 2, which are over the counter.
Over the counter, exactly.
You talked about changes in your skin when you go through menopause or perimenopause. What kind of routine should we have with our skincare when it comes to menopause and after, right?
Well, exactly.
Because you're talking about estrogen, so...
Right. And there are estrogen receptors on the collagen fibers, and aging in our skin is really about long-term sun exposure for sure, and so always wear sunscreen, and then loss of collagen. So we don't prescribe estrogen for skin reasons. We prescribe it for hot flushes and for vaginal discomfort. But it has other kind of ripple out effects, one of which is that it can improve moisture and just that flexibility of the skin. So certainly sunscreen every day, moisturizers. Some people do retinoids, topical retinoids, and so we have dermatologist partners that we certainly can refer people to if they're concerned about that.
Let's talk about, you suffer the symptoms at home. Well, you suffer them 24 hours a day if you're going through menopause or even perimenopause, right?
Mm-hmm.
So when you're at work, what can employees or employers do to make it more accommodating if you're going through this?
Right. That's a really great question. And it's something that we at the Program for Menopause and Healthy Aging really want to get that message out to employers, that it's beneficial to them as employers to provide support for their employees that are going through this process, because uncontrolled hot flushes and menopausal symptoms are a cause of work absenteeism and decreased productivity at work. And so providing support just in the way that we provide breastfeeding spaces.
Right, lactation rooms.
Exactly, for breastfeeding moms. If we can have fans, if we can have adjustable thermostats, if we can provide that
soothing music,
cognitive behavior therapy,
yes,
employee assistance programs, there are many ways to help support productivity of the employees that are going through menopause.
Because many women are suffering silently. Sometimes those symptoms aren't visible, like the sweating.
Lisa, that is so true. And in studies looking at this, women managers, people who are at the height of their careers, people who are leaders and CEOs and really where their careers are just amping up, they talk about this and they say, I don't want anyone to know. This is not something I'm going to allow to impact my work performance, but it does. Yeah. And so I think it's a shame that we feel like that's something we have to keep to ourselves rather than say, let's provide an environment that's supportive of this.
I think, talks like these help a lot. Just get it out in the open.
I hope
Let's talk about it freely and openly, and you have great advice. We talk about women. What about men? Do they go anything? Do they go through anything like menopause? I mean, we always hear about erectile dysfunction, ED.
Right.
So what do men go through?
Right. Well, they don't go through menopause.
That's
they don't have ovaries.
You are so lucky, men.
I don't know. I kind of feel like ovaries are a superpower. I don't know. But they don't. They just have a much more gradual decline in testosterone over time. And I don't want to set myself up as an expert in men. I have wonderful urology colleagues and things, but there are a significant number of men who do take testosterone because they have low androgen levels, and erectile dysfunction is certainly a thing. And so you add erectile dysfunction to vaginal atrophy, and you have a real recipe for not having a fulfilling sex life with your partner anymore. So I love it when my patients come in with their partners. Some of them have female partners, some of them have non-binary partners, some of them have male partners, but I always love having the partner there, because this is a shared experience that you're going through together. And although you can have sex by yourself, sometimes you have a partner, and you want your partner to be aware of that as well.
That's some good advice. Let's talk about stuff that, things that you should be aware of when you are going through this, this phase of your life. What do you find when the women come into your clinic? What are they seeking most?
Two things: symptom relief and long-term health benefits. And I can't say that one is more important than the other. And they want to feel better, but they don't want to take something that is going to damage their health. And unfortunately, hormone therapy has had the worst PR campaign in the history of the world, because people are terrified of it. And it's because of the messaging that has been out there for so long. And what we know now, in the past 5 or 6 years, we've just really refined our knowledge of this. And we realize now that all those negative messages didn't need to be so negative.
So, we're talking about it openly now, that is menopause. What do you think should be done in terms of keeping that conversation going, being more open about it. Tell us about your problem so we can help you.
Right. I think that women are taking this into their own hands, really. I mean, menopause is having a moment. It really is. And you can't open up the New York Times or go on Twitter without hearing somebody talking about it. And I think that's wonderful. It's the same generation that took birth out of the hands of the medical profession and put it in the hands of women. That generation who said, yeah, I'm not necessarily saying everybody should have their babies at home or anything like that, but that unmedicalizing of a natural process, understanding that your provider is there for guidance and support and safety and advice, all the things that you go to them for. But also saying, look, I'm gonna advocate for myself, and I'm gonna talk about what's going on. I'm gonna keep looking until I find someone who has the answers. And I think that's really individually driven, which is quite wonderful. And those of us on the provider side really want to partner with those folks and help to get that information out.
And when you talk about answers, you also talked about, menopause being in the news within this last year. Article after article, treatment after treatment, and one of those treatments is metformin. What are your thoughts on that?
Metformin isn't really in the list of treatments for menopause. Now, menopause is associated with weight gain, and it's a tough one, because if you eat exactly the same and you exercise exactly the same as you always have, in menopause, on average, you will gain about 5 pounds, and it will be right here. And some people gain more than that. And so metformin is used for weight loss. It's used for management of prediabetes or diabetes. And so many of the diabetic types of drugs have been shown to be beneficial for weight loss as well.
Aside from taking a drug, though, how do you, try to keep off those 5 pounds? Any kind of advice there?
Oh, absolutely.
We're all listening.
Well, I wish estrogen would just make it drop off. That I can't promise that. That doesn't happen. It does tend to mitigate the weight gain a little bit, but the number one thing in menopause is strength training, because you have to maintain that muscle mass, because the muscle begins to deteriorate, and then it also becomes marbled with fat, and fat is less metabolically active than muscle. And so two people at the same weight, if one is more muscle and the other is more fat, that person who's more muscle is going to burn more calories. So building muscle mass, core strength, really important for long-term health as well. I think the key to staying young is keep moving. And so that's really important. Dietary guidelines are important too, but exercise is good for so many reasons, but you cannot spend enough time on the treadmill to work off the calories in a bowl of pasta. And so weight management is about what we're eating. Exercise is good for so many reasons, but what we are eating is really going to determine whether we're gaining weight or losing weight. And so you can have pasta. You absolutely can have pasta.
Thank God.
I know. Well, I don't want to live if I can't.
Can I have the bread
if
too?
I can't have pasta. But you can't have it every day. You just can't have it every day. So pay attention to both things, recognizing that exercise is going to help keep you young, and what you're eating is really going to determine whether you stay the same, or lose.
So core strength, not so much cardio, or?
Cardio is also essential, really, and you want to cross-train. So strength training 3 times a week, cardio on the other times. Target about 5 days a week of exercise with a couple days for rest. Some people say, well, I target every day because then I figure I can get it to, maybe 5. And I think that's really reasonable. But yes, some cardio and some strength training.
So thank gosh for that, because what I do is I do the Peloton like 3 times a week, and then I run 3 times a week. So I try to mix it up that way. But I also mix it up with the pasta and the pizza and the bread and the ice cream.
I love pasta, pizza, bread. I have never been a runner, and I have tried, but I love yoga, and I love high intensity interval training, which I love it because it's so efficient time-wise. Because I was trying to do 10,000 steps. It was taking me 2 hours, and who's got 2 hours to walk around? I wish.
So while we're talking about, tips, good news, what you can do to keep off the LBs, exercise, eating right, there's a lot of research being done in the field of menopause. What are you most excited about in terms of that research?
Right. So that circles back to the study that really made everyone go off their hormones, and doctors stopped getting trained, and nurse practitioners and PAs, and that was a study called the Women's Health Initiative, and that was the largest trial that the NIH had ever sponsored, and it will never be repeated. It was so expensive and time consuming, and what happened was they stopped it early because of increased rates of heart attack, stroke, and breast cancer. And it hit all of the airwaves, and the phones were ringing off the wall in our clinic that day. Heart attack, stroke, breast cancer with hormones. So everyone went off, and it was on all the news shows, and for 20 years that was the state of the science. And then the data has been followed, and we've reanalyzed, and there's been some new studies, and what they found, and this is really important, is that younger women behave differently on hormones than older women. Meaning that if you are under age 60 or less than 10 years out from menopause, so if menopause is 50, 51, you've got 10 years, and if you go on hormones during that time, you are not going to have all those increased bad outcomes. And in fact, 15 years later, you're going to have better bones, you're going to have fewer bone fractures, better bone density, and your heart is going to be healthier, because we all are depositing calcium in our coronary arteries and our hearts. That's just happening with everyone. But that process slows down in young women who take estrogen. And we just found that out in the past 5 years or so. Wow. So, because when they did that study, that big study, the people in that study were 50 to 79 years old. The average age was 64 in that study, and they were starting people on hormones. So that data was being used to inform our treatment of people in their late 40s, early 50s, when it really didn't apply to them. So that's a very important message, that people under 60 really get tremendous benefits. And then once you've passed that realm, then you can either decide to stay on it or go off of it, but we don't usually start people on hormones after kind of mid-60s because the risk-benefit balance doesn't support it any longer. So that's what I'm super excited about.
That's good to know. The title is Ask Me Anything, so we've been getting all these questions from our Instagram viewers. One of them is, what do we not know about menopause?
Wow, that's a great question. What do we not know? Sometimes we don't know what we don't know, right? But if I could wave a magic wand and get some information, what I would want to know is what about other forms of hormones than the ones that were studied in the Women's Health Initiative? Because the Women's Health Initiative studied 2 very specific types of estrogen and progesterone. And we don't use those as much now as we do some other ones that are more bioidentical. And we extrapolate the data. We say, well, it behaved, this was what we found with that. We think it's the same with this, but we don't really know. We think it is. We also don't know if it's dose related. So does half the dose give you half the risk?
Yeah.
We don't know that. Is it an all or none phenomenon? So dosage and route of administration and the pharmacologic makeup of the particular drug, those things we don't know, and I wish we did.
Yeah, I mean, one size does not fit all.
That is absolutely the message. One size does not fit all. We individualize for every single person.
Right.
And it's not that kind of, this is how I do it, I'm going to give you what I always give. That's if somebody says that to you, you should get up and walk out.
And speaking of messages, as we end our Ask Me Anything segment here, what is your core message about menopause? A couple of pieces of your best advice.
Best advice is, if you are not feeling it, that's great. You're in that 20% that doesn't feel it, but you should still go talk to your provider about maximizing your health in this period of time. If you are feeling it, there are so many good, reasonable, accessible treatments and people who know how to treat this. So seek out a certified menopause provider, which the North American Menopause Society certifies experts. That as menopause experts, you can go on that website and put in your zip code and find somebody who knows what's going on, because not everybody does. And so seek out the answers that you need. And then recognize that the second half of your life is better than the first half.
That's great. And that's sort of the impetus of starting this menopause and healthy aging clinic here at Stanford.
Absolutely.
Well, thank you so much for joining us today for Ask Me Anything. The topic, of course, was and still is menopause. But, as you said, you still have to look forward to the rest of your life. This isn't it. You don't have to suffer. Thank you so much, Karen Adams, Director of the Menopause and Healthy Aging Program here at Stanford. Thank you all for joining us today.